Good morning, everyone. Thank you very much for joining us for INTENT, International Teaching for ENT Surgeons, the second webinar in our series entitled Nasal Obstruction. My name is Aurelian Geru, and I'm the co-course director of INTENT. Just a quick recap of the format of the webinar, which will be the same as the last one. So we've got 6 topics, 6 webinars. The first part of the webinar is half an hour long, and we'll lay out the patient journey of a patient with nasal obstruction in the UK. The second half hour will be a discussion forum with UK experts. And the third part, there's a reflective and evaluation form for you to complete. Once you've completed that form, we will give you your certificates of attendance. Like we did last time, please write your questions in the Zoom chat, and these questions will kick off our discussion forum. Alternatively, if you would like to write your questions in Mongolian, please write them in the group chat. Gan has got access, or you can message him directly and we will get to them. So it gives me great pleasure to introduce our 2 specialists for today's session, Mr. Nick Aynon-Lewis and Mr. Eamon Shamil. Thank you very much.
Good morning, everyone. Pleasure to be here. My name's Eamon Shamil. I have just started a rhinology fellowship in London and just recently finished my training. I hope I don't run into the same connection issues, but I'll try and keep my eye on the chat to look out for those. So most of the images from this talk are from this book that was recently published and had the pleasure of working on. As Nick mentioned, nasal obstruction can be subjective or objective. The subjective ones we have less influence over and are influenced by your mood, temperature, and the objective ones are things that we can have a little bit more surgical control over in terms of improving nasal resistance. So septoplasty is a very common surgery within the UK. We do over 20,000 of them. However, satisfaction is relatively low. We often don't get it right the first time. We always need to warn patients about failure to improve or recurrence of symptoms. And there are many different ways of doing them, including endonasal, endoscopic, and external approaches. So if the nose is a house, the septum is the foundation, and we have the privilege on working on that and trying to improve the foundation, and we need to be architects when we're approaching it. I'm going to try and keep this talk quite surgically relevant, as I gather that you all have experience in performing septoplasty. So we'll talk about things like exposure, how to repair deficiencies, and the L strut, both dorsally and caudally, and maintaining at least 1 centimetre, ideally 1.5 centimetres in that. So just to quickly run through the nasal valves. So we've got external here on the left, middle, internal in the middle here, and then I've just got a cross section. So the external nasal valve has your septum medially, your alar rims, which is your lower lateral cartilages on the lateral side, and then your sill at the bottom. And if we go a bit further back in the nose, if you're doing anterior rhinoscopy or nasendoscopy, you can see your septum here medially, your upper lateral cartilage here at the roof, and this is the inferior turbinate here. So these are areas that we can tackle during our operation. I've put a cross section here just to show you that, and Nick had a slide on this as well, that nasal airflow often goes along the inferior turbinate, but about 50% of it will hit the middle turbinate or the middle meatus, and that's something that we should consider, and perhaps we can discuss more on how much should we address middle turbinates during sinonasal surgery. Whenever you're assessing a nose in clinic, try to make a plan of how you're going to do the operation. I think the Cottle's classification helps, and this dotted line here is where the internal nasal valve is. Number 1 is the caudal septum, number 2 is the internal nasal valve, and then you can think, high mid-septum, low mid-septum, or posterior septum, because if you've got a very high deviation or a very severe caudal deviation, then you think in your mind, okay, do I need an open approach to try and address this? And if it's a very posterior deviation, you may benefit from using an endoscope to help you get a better view intraoperatively. So we'll just talk through some of these techniques, and again, we can go into more detail about them, but these tend to be the working horses of septoplasty approaches. So you can either do a swinging door technique where you mobilize the septum off the maxillary crest and try and secure it in the midline to the anterior nasal spine. These are good for caudal deformities. You can remove segments of the septum, so you may have a very obvious and easy to remove spur, or you may have a very severe deviation with a fracture line through the septum that can be resected. And then, adjuncts include, scoring the concave side of the cartilage using sutures to try and straighten the septum, and also reinforcement grafts either from the septum itself or the perpendicular plate of the ethmoid, or if needed, the contral bowl. So I'm just going to talk through some of my top tips that I've picked up over time and from different trainers across London. I really recommend using magnification. I have loops that are 2.5 and a headlight, and that's integrated within the loops, as that gives a better beam into the nose. I really like using the endoscope, especially for more posterior deviations, as I mentioned earlier. I think it's an excellent training tool. If you're training, registrars or SHOs, you can watch them do things like raise flaps and give them tips on which layers they're in and how much septum to resect and so on and so forth. There are different types of incisions one can use. So we've got here the hemitransfixion incision, which is a traditional approach. The Killian incision is about a centimetre further back from the caudal septum. And then you can do a modified Killian incision, which extends onto the floor of the nose. And something that I picked up from different trainers and textbooks, including Dean Turiumi, is to try and put your mucosal incision in the vestibular part of the skin, as it's thicker and less likely to tear the mucosa. Always try and stay below your internal nasal valve whenever you're making any Killian's incisions. This happens from time to time. You can tear one flap, and how to address that is debatable. Some people will say it's just a drainage hole. Others will say, okay, let's repair it primarily. I think certainly we all would agree that if you tear both flaps, you should try and put something in the middle of it. So that can be either cartilage that you've already harvested or removed during the operation, or you can use some fascia, either from the ear, or if you've taken rib, you can use the perichondrium there as well. I would always use nasal splints if there was any concern about this, and leave them in for 3 weeks, and just assume that that is the bare minimum that you need to do. Give them some antibiotics as well, and just inform the patient afterwards that this has happened, just in case they do end up with a septal perforation. If you remove any cartilage, do your very best to reinsert it. So you can cut out the deviated parts, or you can dice it if you've got time, and using one of the dermatome blades, and then just stick it back into the septum wherever you removed it from. And it's also good for your own evaluation and auditing purposes to try and use questionnaires. Again, Nick mentioned the nose, it's nasal obstruction symptom evaluation one, and you can do this pre and post-operatively, and this is a useful way to show your hospital managers that this operation works and that we should carry on doing it, because it's been an area of debate, certainly in the UK. So just quickly going through the swinging door technique, this is very good for addressing caudal deviation. So where the posterior septal angle, or the part of the septum is just over the anterior nasal spine, has subluxed, you can address it by trimming a little bit of the inferior-most caudal cartilage, but leaving an area that can slot within the anterior nasal spine. You need to avoid deprojecting the tip when you're doing this, so don't resect too much of the inferior caudal septum, and if the anterior nasal spine doesn't have a very deep groove, you can use an osteotome very gently to deepen the groove within the anterior nasal spine, and then use 4-row PDS sutures to try and secure the septum into the midline of this. I find this a very good way of stabilizing the septum. You can use additional adjunctive techniques such as scoring the concave side of the cartilage, or even putting septal graft or perpendicular plate of the ethmoid along the caudal septum to help splint it. The next technique that's commonly used is resecting an area of deviated septum. So you can see in this picture here, we have got a big fracture line that's going along the anterior septum. So you can resect this area of cartilage, resect the fracture line at the same time, leave enough of a dorsal and a caudal strut, at least 1.5 centimeters if you can. Okay, and then again, cut out in the cartilage that you've removed, cut out the deviated parts and try and make it nice flat pieces, and then reinsert it within the septum. And in this situation, you know, raising wide bilateral hemitransfixion, mucoperichondrial flaps, you know, really helps, and getting good exposure is critical. The final thing that I'll just cover is on a nasal valve surgery. So here you've got your septum and your upper lateral cartilages, and they form a tent-like structure, and the angle can be improved by inserting a graft between the septum and the upper lateral cartilages. So these sorts of things, again, require an open approach to try and improve the nasal valve. I've mentioned here at the bottom alar Batten rafts. This is for the lateral strut crust of the lower lateral cartilage to be strengthened either using septum or conchoid cartilage as well. Again, it's an open approach. Final few things I just wanted to mention. Take your time when consenting these patients, warn them of the failure to improve, warn them of the recurrence rates that you might get. Something that patients always say annoys them is the numbness in the upper lip or teeth. So warn them about those sorts of things, as it can affect their quality of life. And then all these other complications, you know, which are standard, should also be included in your consent form. This should say 4 to 8% of adverse nasal shape, which again is something that you should go into detail about, especially if you're planning any you know, significant resection of septum or work on the L strut. A couple of debate points. So inferior turbinate hypertrophy, how should we treat it and when should we surgically approach it? So, you know, you often get enlargement opposite to the side of the deviation, which is compensatory, and histological studies have shown that this consists of both mucosa and conchoid bone. There are a large range of techniques ranging from, you know, out-fracturing them to coblation or radio frequency reduction to resecting the turbinate completely. I think the most important thing is, you know, to warn the patient that this can just be a temporary fix. They can get bigger again if you're not resecting the whole thing, and you can get quite nasty complications or quality of life impairment, I would say, with crusting and adhesions of the turbinate to the septum, which will just, you know, undo any good work that you've done with your septoplasty. Another area of debate I mentioned earlier is about middle turbinate reduction. Before, this used to be completely forbidden in ENT surgery, but I think you know, we're becoming more kind of aware of the effect of middle turbinate hypertrophy, and certainly, you know, we would reduce a concha bullosa in an endoscopic sinus surgery, but this is something we should consider also in patients who've got nasal obstruction undergoing septoplasty, having a closer look at the middle turbinate in your preoperative evaluation. And I recently attended PJ Wormold's course, and you know, he was talking about the same things, about how over time he's become more aggressive with reducing the middle turbinate in patients with nasal obstruction. This is because of 50% of airflow crossing the turbinate. Final thing, this is an excellent website. It's got lots of videos on rhinological procedures, including septoplasties, full house fez, and sphenopalatine artery ligation. It's completely free to use, and all the videos are on YouTube, and I've been given permission by the authors to use it. So we'll just go through this. This is resecting a spur. So I would inject some lignospan, both here caudally, within the septum, to help with hydrodissection, and also helps a little bit with post-operative pain. The approach here is the left side, and they're going to do a hemitransfixion incision with the blade going down to expose the cartilage. And you'll see in a moment that iris scissors are used to try and help get into the correct plane. Getting into the correct plane is, the challenge that people face from the beginning of their training to the end of their careers before retiring, and it can be very challenging, especially in revision cases or severe trauma. So taking time on this part really pays dividends later on in the operation. And you can see here, I really like using the iris scissors to help get into the right plane. Nice sharp pair of scissors. Once you get into your right plane, you use your freers to raise your mucoperichondrial flap. Again, in revision cases, my tips are, try and find it either high up, in the dorsal L strut region, or low down, as these are areas where the cartilage is less likely to have been resected or disturbed, and it's easier to find it there. So just speed this along a bit. So flaps have been raised. Now this is the use of an endoscope. Again, this can be used as an adjunctive tool or as a primary tool in spurs that are further back in the nose. You can see that there's a spur here, and the freers is going to be used to resect this spur, essentially. And you can see it's an excellent view. Your theatre nurse can see it at the same time, so they know what instruments you're likely to need next. And you can see that he's keeping the flaps intact on both sides here. And you can be conservative with your resection to start off with, and resect a bit more if needed after reassessing. And this is the resection of the spur. So thank you very much.
So we actually do have a question on the chat now. So for both Nick and Eamon, first question is from Dr. Sukhpatal. There are 3 kinds of incisions in the antenasal approach for septoplasty. Which incision is more appropriate to use in an Asian patient? Eamon, does that question make sense to you, or is it more, I'm wondering whether it's morphology of the nose or conditions of the nose. Gan, maybe you can expand on that. What is meant by that question?
I think just generally speaking, the incision used can be tailored to the pathology that you're trying to address. So certainly if you've got a very caudal deviation, then you want to use hemitransfixion incisions, and if it's something a bit further back, then you can consider your Killians. And then, as mentioned, the open approach, you want to reserve that for very severe caudal deviations, high septal deviations, or if you think the internal nasal valve needs to be improved.
Gan, I know you're a rhinologist. Do you have any questions from your colleagues? Otherwise, I have a question for you. What techniques do you use in your practice, and how the UK and Mongolian approach is different?
Before answering your question, I need to ask one question first, and most of the attendees, the current participation, most of them are the residents. What they really want to ask first is of course, there's a septal deviation, the causes, so whatever. But if a significant or specific deviation is based on that. So which incision should be more specific to the anterior or just the caudal deviation or the middle deviation or just the posterior bony deviation? Which incision should be significant based on the behavior? By the way, thank you for a great presentation, Eamon. And then I can just answer the comparing issues about UK approach or Asian approach. Then I can mention that.
Maybe I can share my slides again, and then I can show you on some pictures, you know, what we can do. So it's useful to know that the majority of people are residents or in training, and I can completely empathize as you know, this is no doubt one of the most difficult operations to learn, because you can't always see what your trainer is doing, and also getting consistent results is extremely challenging. As and when you start to follow up your patients longer term, you'll see that unfortunately, you know, you thought you did a good job, and at the end of the operation the septum was straight, and then they come back 3-4 months later and it's deviated again, or even longer than that, and that happens to everyone, unfortunately. So it's just trying to find approaches and incremental learning. So you know, every operation, just have a think about what you did, whether you could do anything more, watch videos online and read books. There's lots of excellent free resources available. So regarding the incisions, just going back, can you see this slide here, Aurelian, the one with the different incisions?
We can, yeah.
Yeah, we can.
So, you know, so we've got our hemitransfixion here, which is right on the caudal part of the septum. You've got your Killian incision, which is a bit further back, and then, you know, modified incisions can go along the floor, and you know, the one that I mentioned about the modified Killians is kind of between the traditional Killian and the hemitransfixion. So which one to use? Now, I think to start off with, to be honest with you, especially if you're training, you can do a hemitransfixion incision for every single septoplasty. And it's good to get that practice of approaching the caudal septum, getting in the correct plane. And when I was starting off, you know, and some people may agree and say this isn't the right thing to do, but you know, my trainers encouraged me to raise bilateral flaps, okay, with a hemitransfixion incision. And the reason is, and starting with the easier side, of course, and by raising bilateral flaps and being confident that both of them are intact, then you can say to yourself, okay, you know, I can do whatever septal work I need to do, and the flaps are going to come back together. The risk of just raising one flap at a time means that, you know, if you're not used to the delicacy of resecting septums with just one flap raised, you may go through the other side and tear it. Until you've got a feel for what tissues are like, and that can lead to problems, unfortunately. So I would encourage that as a practice tool, and also, you know, to get good outcomes and a good view, raise bilateral flaps with a hemitransfixion incision and go all the way back to your bony cartilaginous junction, and then you can see everything really clearly. I think, you know, the Killian's, you know, incision, you know, some people, you know, don't use it at all, and it's just a quicker way of getting into a very localized spur, for example, or a localized deviation, and I especially use it during endoscopic sinus surgery if there's a deviated septum that is obstructing the middle meatus or my access into the sinuses, and I find that's the time when I use it the most, and I'd encourage you to use the endoscope as well. Have it ready at the beginning of the surgery. Have a look at the beginning of the operation with your endoscope. Look at the inferior aspect. So going back to the anatomy pictures. So, you know, this area here in the middle where your internal nasal valve is, you know, upper lateral cartilage, septum, inferior turbinate. This is where you're getting the most resistance in the nose. So, you know, you want to carefully look at this, but also go further back along the floor of the nose, looking for septal deviation. Look at the inferior turbinates, how bulky are they? Look at the middle turbinates, you know, do they need nutrient? But be very cautious if you're doing any middle turbinate resection. I think if you're a training registrar or resident, you know, ensure your boss is around and agrees with it. You know, middle turbinate resections or manipulation can cause you know, catastrophic complications like a CSF leak if you're not careful. So so don't go crazy doing anything there, especially when you're starting off. Does that answer any of the questions a bit better, Gan?
Any of the questions? What? I missed that.
Did that answer your question, Gan?
Oh yeah, sure. In addition to that, actually the question from Eamon, also the Aurelian, the basic concept that we approach to the septal deviation on behalf of us is mostly it's the Mongolians are the located in the center of the Asia, so anatomical variation is mostly similar to Asians, 80% or more than that. So we have to follow the guide of mostly the Korean, the concept of the septoplasty, which mentions for example, I'm trying to make it more distinct to the residents in addition to Eamon's statements. The first one is for example, as I mentioned last time, is for example, caudal deviation. We mostly do the open approach for using the spuritic graft. So it's somehow the caudal deviation that can cause the high deviation that can impairment of the middle meatus blockage somehow, that can also be a cause of sinusitis. Also, if it's so at that point we can use the transcolumnar incision. Secondly, if it's the middle portion deviation, we can use just the modified Killian incision. Just also we can use it just a hemotransfection, or then also modified Killian incision, or we can just use endoscopic septoplasty. And if it's just the posterior deviation, we can also use this endoscopic septoplasty plainly. So that's the thing that I would like to more distinct to the residents. Yeah.
I think there was a question about how to fix the septum to the anterior nasal spine. So I just thought I put this picture up. Should I go ahead and answer that?
Go for it, Eamon. Yeah, there's that one, and there are a few others in the chat as well. But start with that one. Be great.
So this is the anterior nasal spine here. You know, this Y-shaped structure, and there are different ways of fixing the septum. So first of all, you want to try and get the septum to sit in the middle of this groove. And sometimes, you know, the groove doesn't exist, or it's been fractured, and that can make things very difficult. So, you know, you can try and deepen the groove. Again, I think it's a bit of an advanced technique, using an osteotome very carefully, because you don't want to fracture the whole thing. Other instruments that are coming kind of to the forefront now are the piezo, which allows for a bit more kind of precise dissection. But regardless, try and get the septum into the middle of this structure, and then you can either put a suture, 4-0 PDS suture, through the periosteum of the anterior.
Brilliant. So just to summarize what Nick said again, because the connection wasn't great, but you can also manipulate the spine, is subluxated, to help you fix it. Eamon, we lost you. You back? Hello?
Sorry.
Oh, you're back.
No
worries.
You guys have probably gathered that the UK's internet connection is not very good.
So Nick finished your question for you. Thanks, Nick. But
Thank
again,
you.
his connection's a bit shaky. So maybe your connection is better now. Can you answer how would you manage bleeding in endoscopic septoplasty?
Yeah, so again, it depends on where it's coming from. So if you've got bleeding throughout your operation, you may not be in the right layup. You know, that tends to cause oozing. And, you know, there are you start to hear arguments nowadays at the rhinoplasty courses and conferences that we don't need to be chondral layer on the septum, gives it more integrity and structure. But I think that, you know, going by the traditional approach of being subperichondrial will mean that you don't get bleeding. If you do, what I'd recommend is getting adrenaline soaked neuropathies, so 1 in 10,000 adrenaline, putting it in the area, just giving it a couple of minutes. You turn around to your scrub nurse and ask them to tell you a joke, or you tell them a joke. By the time they're finished telling the joke, it's usually 1 or 2 minutes, and then you can, if the bleeding stopped. If you've got any bleeding from other parts of the nose, like the inferior turbinates, which you may have accidentally injured, or you may be reducing in size, then it's important to address that intraoperatively. And you can do that with bipolar diathermy, especially on the inferior posterior part of the inferior turbinates. And you know, some of my colleagues have been in situations where they've had to do even a sphenopalatine artery ligation during septoplasties or endoscopic sinus surgery, where it doesn't stop bleeding. And again, it's better to control it while you're in theatre on the table, because otherwise patients are going to go to the ward, they're going to carry on bleeding, and you're going to get called again in the middle of the night to come back and try and stop this bleeding. So having a good anaesthetist who gives you hypotension, the use of tranexamic acid at induction. I use that routinely now for all sinus and septal surgery. And I also use Moffitt's, which is a combination of adrenaline, cocaine, and bicarbonate and saline in operations to try and help. Putting your injection in early. So my personal preference is to inject the nose before I scrub, and I do that for septoplasty and septorhinoplasty. Because the vasoconstrictive effect of the adrenaline can take some time to work to be a bit better. We have a lot of paperwork to do with the WHO checklists. So I know that if I inject before I do all of that, and I've agreed that with the team, then it's going to be 10-20 minutes before we actually start the operation, and then the vasoconstrictive effects can help.
Eamon, quick question.
So there's a few different things there.
Brilliant, thank you. There's a question about extracorporeal septoplasty. Do we use it in the UK? Do you use it in your practice? And what is the main indication? Just about a minute answer.
Yeah, so this is a very challenging operation. I think that, you know, if you're doing that, you need to make sure that you've got experienced septorhinoplasty surgeons with you. You know, it's done for extremely severe deviations, and it involves removing the entire septum or part of the septum and then reconstructing the nose. So you're deconstructing the whole nose and then reconstructing the septum. And it's very challenging to get consistent results. The main thing to focus on is your dorsal and caudal L strut, and ensuring that you have adequate support in both of those regions when you're reconstructing. And I think that, you know, we can provide a talk with pictures and videos of all of that, but the main indication will be severe, especially caudal deviations, or if it's a revision surgery, or if patients had severe trauma, then I would consider that. And that's often, you know, done also as part of a septorhinoplasty procedure for patients. So yeah, I hope that helps.
That's brilliant. Thank you, Eamon. So we're coming to the end of our webinar. So again, I want to ask you the questions that I'm going to ask every week. and you've already answered partly the question about what's done differently in Mongolia. Is there anything you lack or need in Mongolia to, to provide the best care for your patients?
According to the information from the EMN, it's quite similar that we do in here. Actually, there's no misconception between us. Actually, it's quite same. And the problem is, for example, this presentation is quite new and quite. It has a great constructive feedback also, because there's some misunderstanding, intraoperative, some complication like the bilateral flap injury can cause the septal perforation, and how to manage properly first. And for example, that's what I saw, and actually it is quite helpful for the residents. For example, it is quite interesting that we also heard that the 3 weeks of splint attached to the septum is by now, it's, in my point of view, it's very helpful. I think the lack of this serving to the septoplasty management to the people in Mongolia is we don't do any. For example, the post-operative management is quite different in the basin or location of the hospital. I don't know. It's quite related to the concept of training the residents, the trainees, based on that. I don't know why it's so different, but it's really different. For example, post-operative management is at least 1 to 2 days, and actually it doesn't have to be inpatiently. It has to be outpatiently managed easily. So in Mongolia, for example, we have to the patient inpatient at least 3 to 4 days in a hospital, and then we had. But the follow-up days, the length is not quite more than 3 to 4 months. We just follow them up like 1 to 2 months, and that's it. If there's no significant changes, including synechia or just any deformities at because of the inappropriate approach. That's all I have to mention.
I think we're the same. We also struggle with giving long-term follow-up because of the lack of appointments and a very overstretched healthcare system. But
what I think he was trying to say is that some of the issues that you have in Mongolia, we also have in the UK. I apologize for our technical issues. Thank you so much to Nick and Eamon for excellent talks. I think we've got some key messages across despite the issues with the audio. Thank you, Gan, for contributing. Thank you all for participating. The form, the QR code is up on the screen. Please complete the form. The form is essential for us to improve and for us to know whether this is a worthwhile series and whether we should repeat it in future. If you didn't enjoy it, please do also feedback on how we can improve. Thanks so much for being with us. Gan, do you want to repeat those instructions in Mongolian? I think you said you might want to last time.
Yeah, sure, of course. By the way, and thank you for a great informing with the great presentation to Eamon and Nick. Even there's some technical issues, but it won't happen again with them afterwards. So өнөөдрийн вебинарт оролцсон та бүхэнд баярлалаа. Тэгээд өнөөдөр жоохон техникийн асуудал гарсан та бүхнээс дахин уулзалт хүсье. Манай хоёр спикерийн үүдэлтэй нэг тийм асуудал гарсан. Гэтэ дараа нь ийм асуудал гарахгүй байх тал дээр маш хичээнгүйлэн ажиллах болно. За тэгээд одоо хамгийн гол нэг зүйл хэмээг анхааруулхад яг одоо хамрагдаад намайг сонсож байгаа хүмүүс яг энэ reflective form буюу яг энэ feedback survey-г бөглөөд та бүхэн шууд юугаа сертификатаа шууд авахгүй ч гэсэн энийг бүгэлсний дараа сертификат авах боломжтой. Хамгийн гол нь энэ дээр заавал сертификат авахаас гадна ямар ач холбогдолтой вэ гэхээр бидний явуулж байгаа энэ сургалт та бүхэнд хэр ач холбогдолтой, хэр үр өгөөжтэй байсан, мөн яг иймэрхүү сургалт дахин явуулах шаардлагатай. Явуулахаар бол юуг анхаарах уу? Одоо магадгүй бидний явуулж байгаа сургалтын хугацаа богино байж болно. Тэгвэл жоохон уртасгал шаардлагатай гэх мэтлэн өөрсдийнхөө бодож байгаа санал хүсдгийг мөн бичих боломжтой байгаа шүү. Тэгээд яг энэ QR кодыг уншуулах боломжгүйсэн бид нөгөө нийгэмлэгийн групп дээр юуг нь тавьд оруулчин, линкийг тавьд оруулчин. Та бүхэн одоо бас яг чат хэсэгтээ харж ивэл урьдчилан юуг нь формынхаа линкийг бас тавьсан байна. Тэгээ яг одоо холбогдсон дээрээ та бүхэн хамрагдаад энэ формо бүглэхүүл их сайн байна. Yeah, that's it.
Thank you very much. The link to the form, Gan, you have as well if you didn't manage to capture the QR code, and it's in the chat. Thanks for joining us this week. Next week, we have the webinar on Thursday morning on chronic rhinosinusitis. So we look forward to seeing you then. Thank you so much to our panelists, Eamon and Nick. Really great talks. And thanks again, everyone. Bye now.
Thank you. See you next time.